You know, it's wild to think about, but what starts as just a tiny, unassuming cavity can actually end up destroying the bone in your jaw. Welcome to this explainer. Today, we're diving straight into one of the absolute most important topics in dental pathology, periapical lesions. We're going to literally visualize what happens beneath the gums when a tooth goes bad. Let's get right into it.
Okay, let's dive into this. Picture this. A patient walks into the clinic. They might have a severe throbbing toothache, maybe some really noticeable facial swelling, pus discharge, or just intense facial pain. Or, and this is the crazy part, they might feel absolutely nothing at all. Zero pain. And then boom, a lesion is just accidentally discovered as a dark spot on a routine x-ray. These totally different presentations are exactly why understanding periapical lesions is absolutely crucial. So, here's our roadmap for today. We'll start with the anatomy of an infection. Track the whole process from cavity to necrosis. Figure out if it's a granuloma, abscess, or cyst. Look at how to diagnose the problem. And finally, go over treatment and recovery. All right, part 1, anatomy of an infection. To really get this pathology, we have to remember that a tooth isn't just some solid block of rock, right? It's a living organ. Deep inside that hard enamel and dentin is a soft pulp chamber filled with connective tissue. Now look at that definition. It specifically focuses on the apex. Nerves and blood vessels enter and leave the tooth right at the very tip of the root, which is the apex. So if an infection takes hold inside that pulp, it's basically trapped in a rigid box. The only way out is down. It spreads out through that tiny apical opening directly into the surrounding jawbone. And there you have it, a periapical lesion. So how exactly do the bacteria breach the vault? That brings us to section 2, from cavity to necrosis. Think of this whole thing like a microscopic siege. Step 1, you've got dental caries, just a standard cavity. Bacteria break through that protective enamel and dentin. Step 2, they reach the pulp, causing pulpitis. Now this is inflammation inside the pulp chamber, which actually starts out as reversible, but eventually crosses a line and becomes irreversible. Step 3 is pulp necrosis. The swelling literally chokes off the blood supply and the tissue inside the tooth dies. It becomes this perfect, sheltered little incubator for bacteria to just multiply. Finally, step 4. All those bacterial toxins get pushed out through the apical foramen into the tissues around the root, triggering intense inflammation and bone resorption. Okay, part 3, granuloma, abscess, or cyst. So the crucial point is, what does the body do once the bacteria actually breach the gates? Well, it has 3 distinct ways of responding. Check out the massive clinical contrast here. A periapical abscess is an acute, incredibly aggressive response. We're talking packed with pus, intense inflammation, severe throbbing pain, swelling, and a tooth that literally feels like it's popping out of its socket. It's loud and it is angry. But on the flip side, we have the chronic responses, the periapical granuloma and the radicular cyst. Now, a granuloma is really just chronic inflammatory granulation tissue trying its best to wall off the infection. And frankly, it's often completely asymptomatic, maybe just mildly tender. Cysts are also typically asymptomatic and very slow growing, though, if they get big enough, they can actually cause the jawbone itself to expand. Let's zoom in on that cyst for a second, because its origin story is super fascinating. The radicular cyst, which is the most common otogenic cyst, by the way, grows when a granuloma is just sitting there dealing with chronic inflammation. That constant inflammation actually stimulates these specific leftover cellular remnants in the periodontal ligament. They're called the epithelial rests of molasses. These cells get fired up and start proliferating, eventually forming a true cyst with a stratified squamous epithelial lining. And this brilliantly illustrates why taking an X-ray is an absolute must. Radiologically, these 3 lesions tell completely different visual stories. In acute abscess, especially early on, it might show almost no change at all, or eventually just look like a blurry, ill-defined dark radiolucency. But a cyst? A cyst typically shows up as a classic, perfectly round or oval radiolucency with this distinct, hard white line around it. That's your corticated border. Granulomas kind of fall somewhere in the middle, usually appearing as small, well-defined dark spots right at the root tip. Which naturally leads us into section 4, diagnosing the problem. Here's where it gets tricky, though. Not every dark spot at the tip of a root is an infection. We always have to consider a differential diagnosis. There are visual mimics out there, things like an odontogenic keratosis, an ameloblastoma, a traumatic bone cyst, a central giant cell granuloma, or even early cemento osseous dysplasia. Any of these can look suspiciously like a periapical lesion on an X-ray, and that is exactly why we can't just rely on imaging. A thorough, hands-on clinical examination is absolutely critical.
Which brings us to this golden, super high-yield diagnostic rule. A non-vital tooth plus a periapical radiolucency heavily points to an inflammatory periapical lesion. Tooth vitality testing is literally the ultimate key here. By applying cold or a mild electric stimulation to the tooth, we check if the nerve inside is actually alive. If the tooth doesn't respond, meaning the pulp is dead, it's necrotic, and you see that dark spot on the X-ray, you can confidently lean toward an inflammatory cause rather than one of those non-inflammatory mimics we just talked about.
All right, so we've got our diagnosis. Now we got to fix it. Section 5, treatment and recovery.
When it comes to saving the tooth, root canal treatment, or RCT, is the absolute star of the show. Let's walk through it. First, the dentist goes in and physically removes that necrotic dead pulp, that bacterial incubator we mentioned earlier. Next, they shape and mechanically clean out the canals. Then comes rigorous disinfection of the whole space. And finally, they seal the canals up with a special filling. Basically, by completely clearing out that necrotic environment, we stop the constant flow of toxins into the bone. And once that stops, the surrounding bone can finally get to work on the amazing process of regenerating and healing itself, which, can take several months.
Sometimes, actually, a root canal just isn't enough, or the tooth is just too far gone. That's when we have to step up our interventions. We'll bring in antibiotics if there's systemic spread, like if the patient has a fever or cellulitis. A really swollen, fluctuant abscess might need immediate incision and drainage just to relieve all that pressure and pus. If the tooth simply can't be saved, well, extraction is the only way. And for those really stubborn lesions, we might have to look at surgical management, like an apicocectomy, which is removing the very tip of the root, or surgically enucleating a cyst. And I really have to stress this. Untreated abscesses are absolutely no joke. They can spread and lead to some extremely severe, life-threatening complications, like facial space infections or osteomyelitis of the jaw.
Let's move to and see how this builds into our final section, high-yield exam pearls.
All right, let's rapid fire these essential takeaways. The most common cause of these lesions? Pulp necrosis, usually starting from a simple cavity. The most common odontogenic cyst? That's the radicular cyst. And what does it originate from? The epithelial rests of Malassez. Don't forget the tissue differences. A granuloma is chronic inflammatory granulation tissue, while an abscess is acute, suppurative, meaning pus-filled inflammation. And the single most important clinical investigation to confirm your diagnosis? Vitality testing. For sure. Lock those concepts in, and you've got a fantastic grasp on the core of this source material. By really understanding this whole inflammatory cascade, how a simple little cavity turns into a complex bony lesion, you're so much better equipped to recognize the signs early and prevent those serious complications. It's just a perfect example of how tightly our oral health is connected to our overall well-being. So, as we wrap up this explainer, I've got to ask you, which oral pathology topic should we explore next? What is that one condition you've always wanted to look at under the microscope and truly understand? Let your curiosity guide where we go next. Until then, keep learning, keep asking questions, and I'll catch you next time.